Today we're going to be going through some questions about what residency has been like. You guys, after I recorded that video yesterday, some things started to come to my mind. I'm like, do I really want to add this? I don't know. But some of the things I think are challenges also, and these are not very peculiar to being an IMG or not. I think I wrote like maybe 5 things down, is getting feedback. Again, this might be IMG specific, this might just be me specific. Here, people are giving you feedback, most of them mean well. It's just you're in training, right? You're learning. Do you not want to get feedback? If you don't get feedback, how would you know what to improve? But no, in my mind also, anytime someone wants to give me feedback, I'm always like, get nervous and stuff. Like today, I had like a viewed encounter. Like when I was seeing my patients in primary care, my attending was watching me through like a screen and listening and stuff. And I was like, oh my God, I'm so nervous and stuff. But people really mean well. So learning to like get feedback as a collaborative thing, I think that's for me has been like one challenge in residency. So that's an answer to how is residency going. Another challenge would be like how very specialized medicine is in the US. So for example, in the city I live, we have like a lot of substances. So pain management is a big thing because yes, the fact that we want to have good opioid stewardship does not also mean that when people are in pain, they shouldn't get pain meds. So there are just so many things about like, when do you give opioids? When should you do long acting? When are you escalating? This, that. What is severe, mild, moderate? What scores are you using and stuff? Things like that. And apparently we have acute management team. We have chronic management or palliative care team. And so medicine is very specialized here. So I think that's one of the challenges, which I think that's for most people. Learning that, these are like some of the things that I have to learn that are not just medicine now. It's like they're not just diabetes and hypertension, that's what I mean. There are other things. And then, it's very specialized. You have a pulmonologist and you have an interventional pulmonologist. You have a cardiologist and an interventional cardiologist. You have a radiologist and an interventional radiologist. And so like, what does each person do? And then another thing would be insurance. I think insurance is a big one. I still don't really get how insurance works. Obviously, there's some negative things, like so many like bottlenecks with insurance, especially like Medicare, Medicaid, and then private companies like an insurance and stuff. I think the one thing that is a difference would be, so back home, someone has AKI. Obviously, you want to trend their urea creatinine. And for every test that most people are going to do back home, they're paying out of pocket. So they're like, doctor, another test. Like, and sometimes we don't even get to trend these things every day because they just paid how much K yesterday. The next one they can bring is in 2 days. Or like any patient, you're getting admitted, they have to source the money for admissions. But with the insurance and everything, payment will be sorted behind the scenes. Not so when the patient. Obviously, there are hospitals that will not take without insurance. I don't even know how the politics of hospitals work, which is like a whole thing because hospital is still a business. They still need money to stay alive and to run and to put the lights on, to keep the lights on and stuff. But at least from our own resident perspective, when a patient comes and gets admitted and blah, 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 there are people who are going to go take insurance information, registration, like a lot of steps. Even with discharge, a lot of steps that I didn't even know that these things were possible. So my point is, if a patient needs blood transfusion, I just put in the order. Most times blood is going to be available and there's going to be blood. And after transfusion, they're going to get a post-transfusion H&H. I'm not asking you, we need so much, or we need this amount of money to get a repeat lab, right? So in that way, I think I really appreciate it. So in that regard, we are helping with there are no problems with delays in care in that regard. Obviously, other things can still contribute, but at least money, like paying upfront or paying out of pocket for everything is not so much here, so that helps. But again, this is like a very simplified way. There are so many things about people going bankrupt in healthcare and because of like healthcare needs and getting sick and stuff. So I don't really know much about that yet. The other thing is social aspects to care. Hey guys, so much people management in medicine. Like when you're in medical school, you just feel like, I just need to know metformin is for DM, amlodipine is for this. Nah, so many things. Like, can they afford it? Can their insurance pay for it? What is the copay on this one? Will insurance cover this one? I'm discharging this patient. Do they have home? Do I need to talk to case management or social work about a shelter? oh, this person is 70 something, does not have aid at home. He's a health hazard to himself. He cannot go home. Can he go to an assisted living facility with his insurance pay? This person just got surgery. They need 2 weeks of intense physical therapy. Oh, are they going to acute rehab or subacute rehab? Has PT seen them? Has OT seen them? Patient is panicking, patient is anxious. Or there are social issues that are manifesting as like physical symptoms and stuff. Oh my God. Yeah, like I didn't know that there was going to be like a lot of people in, and sometimes with language barriers as well. And you still want your patients who don't speak English to feel heard in spite of them not speaking English. So yeah, so many social aspects to medicine that I didn't like really consider before now. And I think one more thing is thinking like a doctor. This is like now on a personal level. Like it's one thing to know these things. If you ask me, loops, they cause hypokalemia? Of course they do. Thiazides, they cause hypokalemia? Yes, of course they do. You don't give NSAIDs to people who have GI bleeding. But training your mind to think in that regard. Like I think I had a patient once. So they're coming into the hospital. So there's this thing called med reconciliation. It's like, what medications were you taking outside? Which ones do we need to keep giving in the hospital? Which ones are we going to hold to you, go home and stuff like that. So, and then the mindset to already train myself, well, this person was on a thiazide at home. Before I restart thiazide, have I checked their potassium levels? Somebody said, oh, they are nauseated, like they need Ozofran, I think, again, brand names, under Citron. Have I checked that their QTC is not prolonged? You know, things like that. Thankfully, like, I think one thing, again, is, NSAIDs. Before I give NSAIDs, have I checked someone's creatinine? Are their kidneys okay? Like, training my mind to apply, like, these medical things that I know factually, like, book knowledge, and translate it to, like, clinically, like, patients and stuff. But the good thing about it is that there's this thing called, I don't remember the name, but I'll try. But that thing where Swiss cheese model, where we try to like align things so that before an error actually happens, it is caught on many levels. So I think that's like very helpful. So if I mistakenly like put this medication for someone who's not supposed to take it, there's the pharmacist who's going to verify my order and text me and say, hey, this, you know, so these things like Epic sometimes will also prompt you. This person has this. This is a duplicate medication. Oh, have you checked the QTC? It is prolonged, blah, 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 blah. So those things are like very appreciated, honestly.